Thank you. Thank you to the program committee and to SAM for allowing me the opportunity to speak here. I think this is a great opportunity to do something less traditional in terms of a presentation, and those of you that know me, it's kind of a scary thing to ask me to do something that's different because you never know what you're going to get. But hopefully this will be informative and entertaining, and you'll find this presentation valuable. So we'll go through my disclosures. Most of those were mentioned actually in the introduction. So I've been doing cardiac arrest research for 30 years. And if you think over that time, I sort of reflect back on it, the early days as the wild, wild west. And what I'm going to talk about is not how great the research we have done is or how much we've improved outcomes, but I'm going to talk about the mistakes we made. I'm going to talk about the things that we've done over the years where we got it wrong. And hopefully with the idea that moving forward, we'll stop getting it wrong and maybe start getting it right more often. So my goal here is to give you a historical perspective on the evolution of cardiac arrest interventions. I think in the era where we're doing very much evidence-based practice guidelines that get digested down and given to our trainees don't dive deep into the literature and understand what's behind those guidelines well enough to really understand how imperfect they are. Also, I want to give you some insight into the challenges of translating between animal and clinical research, and not just translating from animal to clinical research, but also translating in a circular way. So taking information that we get from clinical studies back to the laboratory and trying to answer the questions that those clinical studies create when they don't give us the answer that we want. And then finally, recognizing the limitations of what we've done so far as a one-size-fits-all strategy for cardiac arrest resuscitation, treating everybody the same way even though they're very different. So hopefully those will be some of the take-home messages today. And then finally, the goal is that trying to, again, learn from our history. So this was a famous quote, "Those who cannot remember the past are condemned to repeat it." And our hope is that moving forward in the area of research, we can not try to repeat the mistakes of the past and be better at it moving forward. So I'm going to give 3 different examples from 3 different parts of resuscitation. So we're going to talk a little bit about BLS and mouth-to-mouth ventilation. We're going to talk in ACLS about epinephrine. And then we're going to talk in post-arrest care a little bit about therapeutic hypothermia. So this is the test where we see if the video works. So resuscitation has been going on for hundreds of years, right? And one of the things that Peter Safar told me when I worked with him is no idea is new in resuscitation. If you think of it, someone tried it before. So this is just one example going back to 1927 of how bystanders were taught to resuscitate from cardiac arrest. And I hope we have sound. It's a silent movie, actually. We have no sound. Ah, here it comes. There we go. And there's so many things wrong with this that wait till you get to. They drive right over the wire. So 1927 compressions. Don't ever stop. Okay, so that was commissioned by the government as a public health service video.
I was taught that at camp in the 50s.
Exactly, right. So chest pressure, and there was chest pressure with arm lift, chest pressure on the front or the back. Yeah, so that was the resuscitation technique up until like 1960, right? So now comes along Peter Safar. And this one, Michelle, you got to close your eyes on this because this one is going to upset you, I think, a little bit.
experimental study you are about to see
This is Peter Safar.
is one of 18 similar studies during which we compared various methods of artificial respiration. We simulated field conditions, first, by selecting as subjects men and women of various body types who weighed between 110 and 210 pounds. Second, by anesthetizing and curarizing these subjects in order to simulate limp asphyxia victims. Third, by having untrained lay personnel perform some of these methods. And fourth, by not using an endotracheal tube. Now you will see the most effective mouth-to-mouth method for use in adults. We call it the thumb jaw lift method. Note the hand positions.
Now watch how
The
hard
right
this is to
hand
do.
pinches the nostrils. The thumb of the left hand is inserted between the teeth. The mandible is grasped at the midline with the left hand and pulled forcefully upward.
Now, this is the spirometer. You can see the ventilations here.
The pneumograph shows tidal volumes of 2,000 milliliters and more.
Okay, so so he published that work in 1958, and basically that really was, in that study he also showed that the traditional techniques of just chest pressure arm lift did not generate adequate tidal volume around 150, which is around dead space. It really didn't have any gas exchange, and this had tremendous gas exchange. And also combined with the work of Elam showed that exhaled air, which they didn't know back then, had enough oxygen in it to oxygenate. So he did these studies with a pulse oximeter on the patients and showed you could maintain oxygen saturation. So this was the foundation for then the first really American Heart Association guidelines in 1963, training people, bystanders in CPR. And you can see that you have chest compressions, but you also have head lift, chin lift, head tilt with the mouth-to-mouth ventilation, 1963. And that's the way we did train people to do CPR for the next 40 or 50 years, right? And it's hard to do. And it's hard even for a physician to do well. And we expected, it works, there's no doubt about it. If you do it right, it works. But the idea is to translate that into a lay public who takes a course, gets a card, and then in some crisis situation is expected to do it well, was where we sort of lost the translation piece, right? This works, it's physiologically sound, but can you really, will people actually do it when it comes time to do it? So, so I actually had the opportunity to work with Peter Safar during one of my research fellowships at Pittsburgh and when I was a resident there. And you know, one of the things he even admitted that back in the 1740 actually, the Paris Academy of Medicine recommended mouth-to-mouth ventilation for drowning victims. So it was known that this was an intervention that could work. But his quote, and this is a paraphrase quote, that he says, "Ideas are easy to come by, but the credit should go to those who convince the world that of their importance." So really driving forward and having an impact in changing care, which really resonated with me a lot. But then we would sit there in lab meetings, and a couple years later when I was there, this was in the early 90s, there was a group in Arizona publishing a bunch of studies about chest compression only CPR and getting good outcomes in their pig model where they would not do ventilation. So they would do just chest compressions with VFib cardiac arrest, and they'd get animals resuscitated, and they would do well. And then these guys, crazy enough, decided to just start doing it in people, right? They didn't do a randomized clinical trial. They didn't have any NIH funding. They just said, this is going to be our protocol for bystanders to start doing CPR with just compressions only. And a lot of clinical evidence accumulated and got published. And then in 2008, it got to the point where the American Heart Association actually put out a special issue, a special scientific statement recommending hands-only chest compressions for bystanders. And that was because the evidence was accumulating that it was equivalent to CPR with mouth-to-mouth ventilation. And then subsequently in 2010, Ben Bobrow and the team from Arizona published a study actually showing that the chest compression only CPR was associated with better outcomes than if people tried to do mouth-to-mouth ventilation. And you can think about it, how long you pause to try to give a breath. Most of the time the breaths weren't successful, so you were just really increasing the pauses in chest compressions is the explanation for why this change. So now, fast forward to here at the, so how did we react to this at the University of Michigan? So
I'm at this tailgate and nobody knows CPR, which is unfortunate because Chuck over here is about to go into cardiac arrest.
Wait, what?
Sorry, bud. Lucky for Chuck, anyone can do hands-only CPR, even these guys.
Actually, I don't think that's...
First, call 911. Then, push hard and fast in the center of the chest to the beat of Let's Go Blue. That's it. No special training, no mouth-to-mouth required. You're welcome. Just keep on pushing till help arrives. Saving a life. It's that easy.
So as a mentee of Peter Safar, he's got to be rolling over in his grave right now. But again, it gets into this question of, and this is one of the fundamental precepts I think we need to think about, is intellectual conflict of interest. When you have discovered or rediscovered a treatment and are invested in it and feel that this is the right thing and physiologically sound, can be can actually impair progress. So someone who has a leader in the field, believes in intervention, it's very much more difficult to translate out of into a different intervention when the accumulating evidence actually shows that there's something better to do. And people argue that what we did over the last 40 years might have cost a lot of lives, right? Trying to train people in a way to do CPR that they couldn't do it. They were afraid to do it. They thought they were going to do it wrong. They were worried about diseases. And bystander CPR rates stayed in the 20% for decades. And now recently, since the implementation of hands-only CPR, the national, who can guess what the national bystander CPR rate is right now for out-of-hospital cardiac arrest? Give me some guesses. I wish it was that high. It's actually 40%. But 40%, we're getting close to half the time someone has an out-of-hospital cardiac arrest, they get bystander CPR, and that was unheard of decades ago, that you would get that high. So, and just for example, this video, we got 23,000 YouTube views. On the U of M alumni Facebook, 125,000 views, and we showed it on the Jumbotron at Michigan Stadium when there's 110 people there at halftime once in a while. So the people you can reach with this kind of stuff is very valuable. And when you couple it with dispatcher-assisted CPR, where someone's seen this, knows it's okay to do it, then there's a dispatcher telling them to do it, it's really going to change the game in terms of bystander CPR. So one example. So the next example is epinephrine for ACLS. So many of you probably have heard the story where this dose of epinephrine came from, but the story is it comes from a dog study that was done in 1904. Okay? So this is a group, Crowell and Dolly, 1904. They were doing asphyxial cardiac arrest, and they started doing different interventions for that. And this is actually from the paper. Right here it said, after 2 minutes of artificial ventilations, we began a saline infusion and then hypodermic injection of 1 to 2 cubic centimeters of 1 to 1,000 solution of adrenaline. And I think that should be 1 to 10,000 solution of adrenaline. So, so basically, that's where that dose came from 1 milligram of epinephrine came from this in 1904, and it got perpetuated through cardiac arrest resuscitation for 50 or 60 years or more. So then, another just sort of dialing back to my own experience, when in 1988 to 89, while I was still a med student, I did a research fellowship, a Sarnoff research fellowship with Chuck Brown at Ohio State. And the people at Michigan don't like me to talk about this, and I think they expunged it from my record when they announced my chairmanship at the University of Michigan. But at that time, Chuck Brown was one of the leaders in the field, emergency medicine physician. How many of you know him or met him? I know Kevin worked with him. So he was one of the leaders in the field, and he was looking at catecholamines, specifically vasopressors, and optimizing vasopressor therapy during CPR, and doing very sophisticated work, radioactive microspheres, measuring organ blood flow in different regions at various times during CPR with various epinephrine and other vasopressor doses. And that work was really foundational in terms of the whole idea of whether high-dose epinephrine would be the right thing to do in cardiac arrest. My work was actually, my own project was looking at doing heart biopsies during ventricular fibrillation and trying to measure how ATP is depleted during that time. So this is a fancy drill that sucks a biopsy out of the heart and puts it in liquid nitrogen immediately. And then Chuck put the plug in the hole of the heart that we made from foam that we got at Home Depot. So, and just to reflect back, so this is the, what SAM meeting is this? Is this the 40th or something like that? So the first SAM meeting after we transitioned from University Association of Emergency Medicine was in 1989 in San Diego. And just to show, this is some of the actual program from that. So here's work that from Chuck Brown's lab that actually was presented by Jim Hoekstra on norepinephrine versus epinephrine cerebral and myocardial blood flow during CPR. You can see a whole session on cardiac arrest resuscitation. And then there was another session that I got to present at on the high-energy phosphate metabolism during ventricular fibrillation. So a lot of interest at SAEM early on about this topic. And this is sort of a summary article that Chuck Brown published on his body of work, looking at different vasopressors and different vasopressor doses on key things in resuscitation. And I'll point out we've heard a little bit about different parameters in cardiac arrest at the meeting today. One of the things that he looked at is arterial pressure, and showing that standard dose epinephrine of 0.02 milligram per kilogram didn't really give you an adequate arterial diastolic pressure, but high dose 10 times as much did, and similar for myocardial blood flow and cerebral blood flow. And that was really the body of evidence in animals that suggested the standard dose of epinephrine that we were giving was ineffective, and a higher dose, but a 10 times higher dose, was going to potentially be effective again, not necessarily looking at outcomes. He didn't do any survival studies, right? He did studies looking at myocardial blood, getting the heart restarted, return of spontaneous circulation, and getting myocardial blood flow, but not whether the animal woke up and would survive later. So he, among others, did a large multi-center clinical trial. This was published in New England Journal in 1972, comparing 0.02 to 0.2 milligrams per kilogram of epinephrine, single first dose, all comers in cardiac arrest, and showed that there was no difference. So return of spontaneous circulation of 3%, 10% higher but not statistically significant, and then survival to hospital discharge was no different in terms of percentage. And very small overall, 4% versus 5% when you take all comers. Now, the key there, though, I realized after the study was done that the average time to give an epinephrine was 17 minutes. And in the animal studies, they're given epinephrine at 10 or 12 minutes after cardiac arrest, so it was a lot further delayed. And in the paper, in the results section, there's a paragraph that talks about early epinephrine. And when they looked at the patients that got early epinephrine within 10 minutes of cardiac arrest onset, there was numerically twice as high survival rate with a higher dose epinephrine, but not statistically significant. So again, could not use that answer. After leaving Chuck Brown's lab in Ohio State, I went back to Pittsburgh to finish my residency and did a research fellowship. That's when I started working with Peter Safar, and we did a rat study looking at high dose epinephrine. And this is was a fun study where we looked at 0.01 per kilo, so that's a little less than standard dose, 0.1 per kilo, and then a milligram per kilogram. So this is like giving a human 70 milligrams of epinephrine just to see if we could push the limit and see what would happen. And we saw what you might expect. We saw an increase in return of spontaneous circulation rate, an increase in survival with good neurologic outcome with standard dose epinephrine. But when you gave the higher dose epinephrine, even though you got more animals back, less of them survived. And I think that was related to the post-arrest complications of high-dose epinephrine with hypertension and pulmonary edema that you really couldn't treat in a rat model. And again, we were given the epinephrine early, so that was 7 minutes from cardiac arrest onset. So what else do we know? So high-dose epinephrine basically went away. So those trials were done. Everyone said, oh no, high-dose epinephrine, or there was even high-dose norepinephrine. All that got thrown away. We went back to standard dose, even though we forgot that standard dose wasn't enough. Right? So in the animal study, standard dose wasn't enough. So here's the only prospective randomized trial that then compared epinephrine to nothing, to placebo. And this was done in Australia. Ian Jacobs was the first author. And basically, again, randomized out-of-hospital cardiac arrest, first dose was epinephrine or placebo. And they actually showed they had to stop the study early because they couldn't complete it. They ran out of money, or I think it was either they ran out of money or the paramedics, there was no longer equipoise with the paramedics and they didn't want to do it anymore. But it was they didn't finish to the power that they actually wanted to do. They showed a statistically significant increase in ROC and admission to the hospital, but survival to hospital discharge was not statistically different, but it was twice as high. So you doubled survival to hospital discharge, even though it's statistically underpowered. So we're still not having the answer to the epinephrine question. And right now, just finished in London, in England, a randomized clinical trial comparing epinephrine to placebo for out-of-hospital cardiac arrest. Enrollment completed in 2018, and we expect the study to be presented sometime in the fall. So this study may say no difference with placebo versus epinephrine. It might say there is a difference with placebo with epinephrine, but my argument is across all of these studies is that the idea that one dose is the right dose for any patient in cardiac arrest is the fundamentally flawed argument. You can do all the studies you want about a certain dose of epinephrine. In some patients it's going to be not enough, in some patients it's going to be too much, and there's going to be some patients that don't need it. And then still we start doing physiologic monitoring of what we're trying to treat, which is getting a diastolic pressure in our patients. We're not going to be able to give anyone the right dose of epinephrine. Okay, hypothermia. Again, hundreds of years old in terms of a therapy. This is a picture from a Russian physician in the field resuscitating an injured soldier with hypothermia by packing him in the snow. American literature, 1958. Same time when Peter Safar was doing his mouth-to-mouth videos. Annals of Surgery in Hospital Cardiac Arrest. A case series showing that patients that were promptly cooled to 32 to 34 degrees for 3 days had a better survival and neurologic outcome. Sorry, Siri's trying to talk to me. So again, this has been out there. It wasn't a new idea. Working with Peter Safar again, he was very interested in post-cardiac arrest hypothermia, and he was, again, had become very skeptical of clinical trials. And I just put this in as another sort of paraphrase quote that he once said to me in some form that the most reliable way to disprove the effectiveness of a cardiac arrest intervention is to perform a randomized clinical trial. Because he was running the brain resuscitation clinical trial network, which was an international network at the time, and every study they did was a negative study. So he did a study with hypothermia in animals showing that if you cooled animals, and this is using cardiopulmonary bypass resuscitation, if you cooled them immediately after cardiac arrest, you could have protection and good neurologic outcome. But if you delayed cooling for 15 minutes, so this is a delayed cooling group, then you lost that protective effect. And that study actually was a very important study in that most of the efforts at that time were then focused on rapid cooling and trying to get someone as cooled as possible rather than trying to deploy a different cooling strategy. And the challenge here was they only cooled the animals for 1 hour, so they didn't do prolonged cooling. And this idea of early short-term cooling was what the focus was. And then subsequently, the clinical trials that were done that worked were a more delayed cooling, but actually doing it for a long period of time. So these were the two classic landmark studies in the New England Journal in 2002, where they achieved target temperature at either 2 or 8 hours, and they had a significantly improvement in outcome. And this really changed the field. This was the first post-cardiac arrest intervention, the first intervention you could do on someone that, after they got a pulse back, that made a difference in outcome. All right? And these studies got reviewed, and both of them have significant design flaws. The FDA would not approve hypothermia as an indication for post-cardiac arrest care because of those design flaws. And then subsequent studies, but it did change our guidelines both at the international level and at AHA, where we recommend this therapy. So we did an animal study on this. So this is what I do. The clinical trials come out, and then I do an animal study to see if it actually really works in rats, right? So same thing. So we did an animal study. We wanted to look at optimizing it, not whether it really worked, but what would this idea of the therapeutic window. So how long can you wait to start cooling the patients before you lose the treatment effect? So we studied hundreds of animals and did post-arrest hypothermia at various durations and onsets, and started it immediately, waited an hour, 4 hours, or 8 hours to see if it affected the outcome. And we looked at survival with good neurologic outcome, similar to what you would do in a human with a survival with CPC 1 or 2. We had a neurologic function score greater than 450. So what we saw was that there was a therapeutic window in the rat model. So normothermia, and we had a true normothermia. We controlled their temperature at 37 degrees in the control group. And if you started right away, you got achieved target temperature within an hour or within 4 hours. You had a significant number of animals that had survival with good neurologic function. But if you got to target temperature at 8 hours, there was no more treatment effect. So there is a therapeutic window. The longer you wait, you're eventually going to lose the treatment effect. So now we get to the TTM trial. So if you delay by 8 hours, you lose the treatment effect in rats. Okay? So now we get to the TTM trial. So this is the biggest trial done in post-cardiac arrest cooling, international study published in New England Journal in 2013, comparing 33 to 36 degrees after cardiac arrest. Many people, there's different camps on what 36 really means. So some people think 36 is a therapeutic amount of hypothermia. Some people think that that's just normothermia. And that's an ongoing debate. But what they showed was no difference in outcome. So why was there no difference in outcome? Well, the way they published their study is that you had up to 4 hours to enroll the patients in the study. And anytime you do studies where you have up to 4 hours to enroll, and most of the patients get enrolled at 4 hours, right, or 3.5 to 4 hours. What they published was their hours since randomization on their graph. And when you plot out their hours since randomization and then add 4 hours to it, you can see that the temperature curves for the two patient populations were really not different for the first 6 to 8 hours after cardiac arrest. So basically, to me, this is analogous to doing a clinical trial to prove that parachutes don't work by not allowing someone to pull the cord till they hit the ground. Right? So if you do a clinical trial and you miss the therapeutic window, and it makes sense that every single study of the 20 or 25 studies that were published out of this TTM trial, every single thing they looked at, there was no difference. It's just mind-boggling how similar the patient groups were. And I argue that that's probably because of the fact that they missed the whole therapeutic window for the treatment, and the patient groups were actually the same in terms of what they saw within the therapeutic window. So what do we have coming up? We have the TTM2 trial. How many people have heard about that? How many people are participating in the TTM2 trial? So now they're going to randomize people to normothermia versus hypothermia. So they're going to call it 37 degrees instead of 36. There still isn't a requirement of reaching target temperature at any particular time. They're going to have a certain time to enrollment, but not a time to reach target temperature. So very likely they might anticipate seeing the exact same outcome if they don't get the patients cooled within the therapeutic window. And again, my concern about this is it's very easy to design a clinical trial, as Peter Safar said, to prove a treatment doesn't work. But I think it's dangerous to design clinical trials, poorly designed clinical trials that cause us to discard therapies that are very effective, or at least potentially effective. And people have interpreted the TTM1 trial as hypothermia doesn't work. Hospitals have stopped doing hypothermia. Stephen Bernard's hospital, Alfred Hospital in Melbourne, Australia, who did one of the original hypothermia trials in 2002, their hospital went to 36 degrees instead of 33, and they published a paper a year ago showing their outcomes were worse. So they had worse survival and worse neurologic outcome, and they went back to 33 degrees. So, but the scarier thing is that many people have just stopped doing temperature management because they've interpreted this study as not. So the take-home message there is it's actually dangerous and potentially harmful to do poorly designed clinical trials. Another trial that's actually potentially coming up, we'll see if NIH funds, I think it's getting reviewed this month or next month, is the IceCap trial. So this is a trial designed by Rob Silbergleit and Will Moyer. This is looking at a duration of hypothermia. So once patients get cooled, they're going to get randomized to different durations of hypothermia, and we'll see if there's a dose-response effect in that regard. And that might go through the new Siren network if it gets funded. All right, so overall, lessons learned to sum up. This is what I feel like. So I feel like Bill Murray, a washed-up movie star doing whiskey commercials in Japan. We are lost in translation, okay? We are doing things that trying to take the animal data, apply it to clinical trials, and it's putting a square peg in a round hole because we don't appreciate the nuances of the animal work, and then the people that have done the animal work don't appreciate the limitations of the nuances of what can be done clinically. And until we get better at that translation in both directions, we will not design clinical trials that are going to give us the right answer. And that's what we really want to do, is design clinical trials that give us the right answer. And secondly, this idea of we got to give up this idea of one size fits all. So ACLS and BLS are training programs that have to train a lot of people quickly and have them remember something. So it has to be very consistent, right? But especially as emergency physicians, we should be able to do something better than that. This is coming from someone who helped write the ACLS guidelines, is on ILCOR co-chair. We're generating all the evidence evaluation from the randomized clinical trials. But in any one, the right dose of epinephrine, the right way to ventilate, the right dose of hypothermia is going to be different in every patient depending on their pre-existing comorbidities, depending on the severity of their injury and their response to therapy. And until we start in real time measuring what Walter Korschetz, the head of the NINDS, says, measuring mechanistic target engagement, building that into your animal models and translating that into our clinical trials, we're going to continue to do large randomized studies that show no difference in outcome and really don't give us the correct answer. So with that, I think I'm just going to do one thing, is thank, a lot of times in my previous lectures I thanked all my team for all the research they worked. This time I'm going to take a chance to thank my mentors. So I've had a lifetime, I've been blessed with a lifetime of mentorship throughout my career, starting with Chuck Brown when I did my medical student research fellowship at Ohio State, Peter Safar during my residency, and then 3 years during my residency, and I did a critical care research fellowship with him. Blaine White, who I subsequently went from Pittsburgh to Wayne State and did a PhD in physiology under his supervision. And that box right there is my K Award application. So it was a stack of papers this big in a box that you send to NIH, and you usually go to UPS at 5 o'clock to make sure it gets postmarked on that right date. So that was the good old days. And you walked it around to get your signatures, too. And then Lance Becker, who's here. Lance, I owe a lot to in terms of his mentorship of me when I was back at Penn. Really taught me the importance of collaboration, especially international collaboration. This is us at Ken Nagao's laboratory, or emergency department in Tokyo, Japan, where they're doing ECMO cardiac arrest resuscitation decades before it was done here in the United States. And most recently, Bob Bartlett, who was one of the inventors of ECMO at the University of Michigan, he and I are partnering to do animal and clinical research in ECMO resuscitation at Michigan. And my hope is that as we deploy ECMO as a resuscitation strategy, we avoid all the mistakes that we've made in the past regarding other ACLS interventions in terms of appropriate translation of our animal work into clinical trials to ultimately improve patient outcomes. So with that, I am done.
So the floor is open for questions.
Yes, in the back.
In terms of getting approval, is it community sort of approval or emergency approval?
Yeah, so I guess the ethics is that there are no randomized clinical trials demonstrating epinephrine improves survival with good neurologic outcomes. So that's a patient-centered outcome. You saw the clinical data that we have, which I think is strongly suggestive that it would be, but then there's a bunch of retrospective studies that have looked, I think are fundamentally flawed, that suggest epinephrine might be harmful. But again, we can spend a whole hour talking about the challenges with those. I don't know specifically in England the caveats about getting consent, but and you may know what they're doing in London, but I think there's enough equipoise among the investigators and the population there that they feel that this is an appropriate study to do. There was a study done in Oslo, Norway, that compared no IV versus IV for out-of-hospital cardiac arrest. So it wasn't a specific drug. It was like basically no drugs versus getting an IV and drugs. And that study actually showed no statistically significant improvement in outcome, but numerically there was an improved outcome with epinephrine, especially for non-VFib arrest, for PEA arrest. So, so again, underpowered studies. And if you just superficially look at the way the guidelines are written, we can only recommend something if we have, a statistically significant improvement in a meaningful outcome. So the guidelines come out saying we say this is reasonable to consider, but we don't have evidence to prove that it's working. It's really challenging, right? But again, I think the ultimate thing would be if we had a way to measure which patients need epinephrine and what dose they need, not just blindly giving them one vial, 1 milligram, because that's what they did in dogs in 1904 every 3 to 5 minutes. I mean, it's ridiculous when you think about it, right? Imagine treating a sepsis patient, starting them on a norepinephrine drip at a fixed rate and not measuring their blood pressure. We'd be killing people.
So again, I'm Andrew Monty from Colorado, and so I'm very interested in this kind of concept of adaptive trial designs that you've sort of alluded to. Inherently, it allows us to more precisely define phenotypes and then treatments for such phenotypes, but I actually am interested in this kind of interaction between EFIC and then this adaptive trial designs, and so I'm interested in your perspective on EFIC as a tool, and then perhaps Dr. Biros's perspective on EFIC as almost a repercussion of these larger adaptive trial designs.
Wow, that's a good question. I'll give a brief answer, then I'll let Michelle talk more extensively. Just from our own EFIC experience, I think it's incredibly difficult to inform the public of what's going to happen, right? Especially in a cardiac arrest. So we did an EFIC for our ECMO study. We have a randomized clinical trial randomizing patients to standard care in the field versus early transport to the ED for ECMO. And the most frequent question we got back is, why doesn't everybody go to the hospital, right? You should take everybody to the hospital. You shouldn't leave anyone in the field to die, right? So you got to step back and just first figure out what the current state understanding is. And then if you add on, well, we're going to adapt this. So depending on the results we get, we're going to do something different. I just think it's going to be hard for the community to be informed about that. So.
Yeah, so actually there's this ICECAP study that was mentioned is going to be an adaptive trial design. Currently the old NET network is finishing up the ESET trial, which is it's an adaptive trial design for status seizures, and it used EFIC. And it actually was one of the easier studies to describe to the community. You have to remember that you have to start out with a premise, we don't know the answer. And so we are comparing head-to-head things that people have tried before, but we just don't know. Some experts say this, some authorities believe that. We're going to find out. So that makes sense to a community, that these are things people use all the time, but we don't have any evidence. Then if we see that one is better or one is worse, we're going to stop that one. And communities like that, because it means that they're actively engaged in the process. The investigators are constantly thinking about repercussions and safety and vulnerability. And so I think that is less of a concern with adaptive trials than one would think. I honestly can't remember if ICECAP is going to be an EFIC trial or not. I don't remember.
It might not be because it's enrolled. I'm sorry. It might not be because it's enrolling after they've been cooled. So I think it might not be EFIC. But
I don't know if that answers your question.
Any other questions?
All right, so we'll move on to the next presentation. Thank you very much, Dr. Neumar.